our group at least is really trying to sort of push to think about this differently, in a fundamentally different way. The suicidal people, by and large, are best treated outside of hospital settings. And suicide contracts are a waste of time and a distraction that, like David Rudd talks about, you really should be focused on crisis response plans, or Beck's group talks about safety plans, or Barbara Stanley group talks about safety plans. You know, really thoughtful series of interventions that the patient will commit to trying should they get in trouble. Because most of these patients really don't know what an emergency is and what an emergency isn't. Well, part of these interventions involve really learning about trying to do different things other than cutting yourself or overdosing or attempting to see if these other interventions might work, and surprise, a lot of them do. And, you know, and then there you've helped them develop a little bit thicker skin, so to speak. They can tolerate a little bit more, they can get through a difficult spot a little bit better. And so with delay, distraction, redirect, you know, and some skills, and it's a little bit of rehearsal and a lot of support, you know, you can avert a death. I mean, that, with any sort of addictive behavior, if you think of alcoholism, or you think of eating disorders, or you think of suicidal behavior, you've got very powerful behaviors that people use to cope. And I think one of the gifts of motivational interviewing is to sort of say, well, why would you give that up? Because the doctor tells you to stop it? That's not going to work. And if you get an adolescent, that's their green light to do the exact opposite of what you told them to do. Or somebody with an access 2 disorder. I mean, there's that defiant, combative kind of element. So in motivational interviewing, or in some of the work that we do, we're sort of saying, well, you know, of course you can kill yourself later. People clearly can kill themselves. By the end of today, probably on average, 85 people will kill themselves. The question is, do you have to be one of those 85 today? And why can't it wait? Everything to gain, nothing to lose. You have the rest of eternity to be dead. What would happen if we really gave this a go, say 1 to 3 months, so use time as leverage, 1 to 3 months, to see, can we find a way for you to deal differently so you don't have to kill yourself? And, you know, in that kind of model, then you're sort of inviting the patient to consider an alternative model. You're not telling them that they have to. And if you are a student of motivation, you're a student of human behavior, that can sort of look interesting, especially if you're not doing it open-endedly, only for a month to 3 months. I can ask a lot of you if the alternative is death and eternity. And so I feel strongly about this, David Rudd feels strongly about this, a lot of us feel strongly that we've got to get much more sophisticated about informed consent, much more respectful and sophisticated about how you negotiate these things with patients. And what I find is, like in the videos that I've shot of interviews and so forth, or when I talk about this in workshops, you can hear these collective gasps as clinicians say, oh, can you really say that? You know, can you really tell a patient that they can kill themselves later? Well, what patients have told me is that when I've said that to them, they find it very empathic. And suddenly, I don't have to fight with you. And I'm willing to hear what you have to say, because what I'm not going to do is now fight with you about whether I'm going to the hospital or not. And so, but I'm also very clear. I'll say, but the law says that if you're in imminent danger, I have to hospitalize you. I have to commit you against your will. And don't expect me to break the law, because that's not reasonable. So short of this, we've got a lot of room here to negotiate. It seems to me it's not unreasonable for a month for you to back burner your option of suicide, for me to try to convince you or teach you or show you that there are different things you can do instead, because the fact is you can always kill yourself later. But if you're going to be in treatment, be in treatment. And I'm actually not interested in sort of a halfway treatment for a month. So you see, it's a very overt, very transparent. All my cards are on the table. I guess it's seductive, or it has a coercive element to it, maybe in a very subtle way, but it's their life.